Good afternoon, everyone, and welcome. My name is Lisa Orloff, and I'm delighted to invite you or welcome you to the Stanford University Department of Otolaryngology Head and Neck Surgery webinar on ultrasound-guided radiofrequency ablation of thyroid nodules. Together with my co-director, Dr. Julia Noel, we're thrilled to have a large audience of diverse backgrounds, people from many geographies, many specialties, and varying degrees of experience with ultrasonography and radiofrequency ablation, attending today to learn more about RFA and how it can serve your patients. And we are going to take care of just a few housekeeping issues first. If you're having any technical issues logging on or navigating the Zoom functions, please use the chat function to inquire to our staff to get assistance. If you have questions about the content of this webinar throughout the hour and a half, please use the question and answer function, and we will try to answer questions in written format as the webinar wears on, and we'll have some time at the end for questions and answers for our panelists. And if you have questions afterwards, please feel free to email them to the same email address where you registered at rjohall12@stanford.edu. And along that note, I would like to add a special thanks to Tasha Richardson and Rajinder Johal for their fabulous administrative support. And without their expertise, this webinar wouldn't have been possible. So again, my course co-director, Julia Noel, and I at Stanford University are happy to include our special guests today, Leonardo Rangel from Rio de Janeiro, Erivelto Volpe from Sao Paulo, and Higino Steck from Campinas, Brazil. Their wealth of experience with radiofrequency ablation will really enhance the experience this afternoon. And our agenda is as follows. We'll start off with Dr. Noel speaking about what is radiofrequency ablation and indications and patient selection for thyroid RFA. I'm going to speak on thyroid and neck ultrasonography and RFA relevant findings. Dr. Noel will address the consent process and expected outcomes and potential risks. I will speak about anesthetic and ablative techniques under ultrasound guidance. And then we're privileged to have Dr. Rangel's video of a live performance of a radiofrequency ablation procedure with commentary from Drs. Volpe and Steck, followed by discussion by Dr. Volpe about long-term follow-up and outcomes after RFA, and Dr. Steck speaking on management of mixed cystic and solid nodules. We do have time at the end for questions and answers, and we all are so enthusiastic about this topic that we could go on all night long, but we're going to try to adjourn after 90 minutes, and we hope to have this be the first in a series of webinars, so we welcome your feedback. With that, I'd like to introduce Dr. Noel, who will speak about what is RFA and indications and patient selection. So let me unshare my screen. I can. Let's see here. Pardon me for a second. There we go.
Okay. Okay, I will go ahead and share my screen. Okay. Everyone able to see that okay? Good.
That's good.
Okay. So hi, everyone. Thank you so much for joining us this evening. We'll start things off by talking a bit about radiofrequency ablation technology as it applies to the thyroid gland, and then review indications for the procedure and how to set yourself up for success when you're getting started by choosing the optimal patient. So radiofrequency ablation is a technology that's actually been around for quite some time to treat solid tumors in the liver, kidney, bone, and lung. And although it's relatively recent that we've used RFA for thyroid tumors in the US, we owe a great deal of credit to colleagues around the world, and especially to the earliest pioneers in Korea for really bringing this to the forefront of our attention and providing so much of the data that's led to its international adoption. So radiofrequency refers to an alternating electric current, and this oscillates in a high frequency range. And as the current passes through resistive tissue, the ions become agitated and they generate a frictional heat. And this causes protein denaturation and loss of intracellular fluid within a few millimeters of the electrode. And these are the basic components of the circuit. So the RF device is a monopolar system, not dissimilar from using a Bovie in the operating room. The generator produces the power, and this delivers the current to the electrode. And because the size of the tip is so small, a really high degree of energy gets concentrated around the electrode that then needs to be dissipated by a large surface area in the grounding pads, which are placed on the patient's thighs to close the circuit. The achievement and maintenance of the correct temperature during radiofrequency ablation is necessary to achieve coagulative necrosis and adequate ablation of tumor tissue. So below 45 degrees Celsius, the tissue damage is reversible. So the goal is really to maintain a temperature from about 50 to 100 degrees Celsius throughout. At this level, cytotoxicity is induced either instantly or within a few minutes, and the damage is irreversible. But at temperatures greater than 100 degrees Celsius, vaporization and carbonization are induced, and this actually creates a char that serves to act as an insulator that actually impedes further ablation. So the indications for radiofrequency ablation are expanding as we see more data about additional applications. But the strongest recommendation and perhaps best place to start when thinking about incorporating this into practice is for benign nodules that are causing either symptomatic and/or cosmetic concerns. And this provides a really attractive alternative to surgery for a patient population who might otherwise be unmotivated to pursue treatment until absolutely necessary, which we know can often result in a bigger scar and just a more challenging surgery. So for those patients also with functional thyroid nodules that are contributing to hyperthyroidism, RFA can resolve or at the very least improve the hormonal imbalance in the vast majority of cases, which we'll discuss a bit more in the subsequent talk. RFA is also a good option for patients with recurrent cancers, particularly those who have had multiple operations, might be at high risk for general anesthesia or just refuse to undergo surgery. And the treatment intent can be palliative for symptomatic relief or curative if the disease is limited to the neck and low in volume. There has been a wealth of more recent data that you may have seen on the treatment of primary microcarcinomas, and these do show excellent rates of locoregional control with RFA. So although we don't currently have guidance on the indications in treating primary malignancies, I suspect this will be incorporated in upcoming guidelines. And there have also been case reports or case series about using this technology for symptomatic improvement in patients presenting with advanced or aggressive tumors, but the tumor and symptom response is very variable, and so lends to an overall unpredictable result. Indeterminate nodules, I'll touch on briefly. They do represent a bit of a knowledge gap in radiofrequency ablation. The limited data we have is mixed. So you'll see in this first study from 2015, of 6 nodules that were classified as Bethesda 3 that were treated with RFA, 2 continued to grow and ultimately required surgical excision, after which they were diagnosed as minimally invasive follicular carcinomas. The second study by Ha et al. Treated 10 Bethesda 4 nodules, and these were reportedly all treated effectively without regrowth after 5 years of follow-up, but you'll notice the size was quite small. These were 1 to 2 centimeter nodules. So overall, just owing to the limited and inconsistent evidence for treatment benefit, RFA is not currently recommended for indeterminate nodules, especially as it could delay necessary surgery for malignancy. So who's the most ideal candidate for this procedure? And really, it's someone with a benign nodule, again, that's causing compressive or cosmetic symptoms. And you do want a reasonably sized target since the probe induces tissue damage a few millimeters beyond. So 2 centimeters is the recommended minimum. And while there's no definitive maximum, as we'll discuss a bit later, the bigger the nodule, the more likely to need more than 1 session. So location is important to consider. You would like to be able to safely ablate the entirety of the nodule for the best result. So those with a mediastinal component that's out of view, or those that lie in the TE groove or more posterior to the trachea, while not contraindicated, are less ideal since you'll likely need to leave a remnant. Composition also matters. RFA is more effective for solid or mostly solid nodules. Though we know many benign nodules do have a considerable cystic component, so we actually have a special lecture dedicated to this a bit later. And finally, nodules that have a lot of calcification are not ideal. They present a technical difficulty to executing the ablative technique. And then a quick note about how we determine benign in regard to thyroid RFA. So the most stringent criteria, this is from the 2017 guidelines from the Korean Society of Thyroid Radiology, is to have 2 benign biopsies. The more recent update from the 2017 guidelines indicate that 1 benign biopsy is acceptable so long as the nodule has no suspicious ultrasound features, like the nodule that we see on the left here, which is a very classically spongiform nodule. And because functional thyroid nodules are overwhelmingly benign, a single FNA is typically sufficient for pre-procedural evaluation. And finally, we'll address a couple special considerations that often come up. The first is how to manage anticoagulation. And this is somewhat surgeon or operator dependent, but in general, as with surgery, it's ideal to stop anticoagulation a few days beforehand, depending on the agent, and it can be restarted the following day if there haven't been any concerns about bleeding or hematoma. Patients who have pacemakers or other implanted devices can still have the procedure, but you want to try to keep the device out of the path of the circuit. So usually this will mean positioning the grounding pads in a different location or using lower power for more brief periods of time. And there is a bipolar electrode that's available, which is the safest option as the current stays between the 2 tips rather than transmitting through the body, and the grounding pads are eliminated entirely. Pregnancy is generally a contraindication, and it would be a very rare circumstance that would actually necessitate treatment during pregnancy. So the safest decision is to postpone until after delivery. And with that, I will stop sharing my screen.
Thank you, Dr. Noel. So I'm going to address thyroid and neck ultrasonography and RFA relevant findings. And I think that by now we are very familiar with the role that ultrasound plays in the management of thyroid nodules in general. And for those in the audience who haven't had the experience of performing ultrasound personally, there's irretrievable loss of information when we look at just static images. And even these videos that we're showing today, like this one on the right and throughout the webinar, that try to capture the dynamic nature of ultrasound, really don't quite do justice to the live interactive ultrasonography exam. So the sequence of the exam in the diagnostic ultrasound really is typically to focus on pathology. And we have to change our mindset slightly when we're looking at ultrasonography in contemplation of radiofrequency ablation. But in general, we start with an algorithm as an examiner that is consistent so that we don't miss areas. And the sequence is really not critical as long as one is internally consistent, but the thyroid exam is typically examined first, and in conjunction with that, the central neck, including in some instances, the larynx may be visible, the pyramidal lobe of the thyroid, all the way up to the foramen cecum or infra and suprahyoid region, and then to examine the lateral neck compartments, looking especially at lymphadenopathy. The salivary glands may be indicated in some patients, but for RFA typically are not necessary. But most scanning is done in the transverse plane with sagittal imaging to corroborate findings in the transverse plane and to perform third dimension measurements. Doppler is also used to assess vascularity, and the exam can be tailored to the situation. Again, I would imagine most audience members are familiar with the guidelines that we commonly ascribe to for determining risk of malignancy and decision-making for fine needle aspiration biopsy. And this shows the diagram from the 2015 American Thyroid Association guidelines depicting a greater risk of malignancy as the characteristics move from the bottom to the top of this table. No sonographic features are purely pathognomonic, but as suspicious characteristics increase, the risk of malignancy increases, and the size at which we would be inclined to biopsy a nodule decrease. Similarly, we're seeing more and more the use of the ACR Thyroid scoring system, which conveniently reduces the risk of malignancy and the likelihood of biopsy down to a single numerical number based on a point score. And although both the ATA and the ACR Thyroid systems have their flaws and leave certain things to be desired, we're focusing mainly on the low risk nodules, the TR1, 2, and 3 nodules, or the ATA low risk nodules, for consideration for radiofrequency ablation. And these tend to be the larger nodules. So again, we are relatively familiar with the advantages of thyroid ultrasonography as the best tool for assessing the thyroid gland, not only nodularity, but the background characteristics of the thyroid. And ultrasound is currently used to guide various procedures, most commonly fine needle aspiration biopsy, as well as to follow up and survey the thyroid and the neck. But one might ask, why should clinicians perform thyroid and neck ultrasound? And there are innumerable advantages, including those listed here. We can perform image interpretation in real time, which, as I mentioned, is better than video capture. There's knowledge of the patient history and physical exam and prior imaging studies, familiarity with the patient's physical findings and anatomy, and sometimes surgical anatomy as well. And ultrasound-guided FNA can even be performed during the same appointment. Ultrasound is a terrific tool for patient education and for surgeon planning and decision-making. And now we can use it to guide interventions besides fine needle aspiration biopsy and alcohol ablations. We can use it to precisely perform radiofrequency ablation. In fact, it's the sine qua non for RFA and other precision procedures. Ultrasound delivers no radiation. It's the least costly of the imaging studies for the thyroid, and it does allow for personalized care and decision making. So on the left, you see the kind of view, you get the big picture view of the thyroid with nodularity that may be hard to characterize on a TI-RADS type scoring system, or there may be nodules that have indistinct borders and may be hard to measure. On the right, you see a lesion in sagittal view that was biopsied and was a follicular lesion of undetermined significance, but when the patient swallows, you can see how malleable this nodule is, which does give some sense of its less aggressive nature, and indeed this proved to be a benign nodule at the time of surgery. So the diagnostic ultrasound exam can be performed with the patient in varying positions. The preferred position is supine with the neck extended, and I would say that for radiofrequency ablation, it is necessary to have your patient supine with their neck extended. But the exam beyond the thyroid gland includes the central compartment, both the paratracheal zones and the pretracheal and prelaryngeal nodes and zones, all the way up to and including the larynx, which is not always visible on ultrasonography, but is often revealing of vocal fold mobility, the infra and suprahyoid regions, all the way up to the foramen cecum. And here you can see a video demonstrating descent through the thyroid and central neck in the pretracheal space down to the innominate artery and innominate vein. And here ascending from the thyroid up through the cricothyroid space and the prelaryngeal region. Here at the level of the larynx, one can adjust the settings on the ultrasound system to a lower frequency to enable visualization of the vocal folds and see symmetrical vocal fold mobility. This is easier in female patients than in male patients, but it's also easier in children. And then continuing on up superior to the larynx to the infra and then suprahyoid space to the base of tongue, where there may be residual thyroglossal duct components or pyramidal lobe tissue. So not to forget the lateral neck and the lateral parts of the central neck, here's the right paratracheal region descending through the thyroid gland down to the convergence of the carotid artery with the innominate artery. And these structures, as you'll see momentarily, are all important when considering radiofrequency ablation. On the left side, we see descent through the thyroid lobe, between the carotid and the trachea, past the esophagus, down through the thymus, and down to the innominate vein here. And the lateral neck compartments of greatest interest in the context of radiofrequency ablation are levels 4, 3, and 2. These are also the lateral components that are most susceptible to metastases from thyroid cancer. Levels 5 and 1 are less often involved, although level 5B is an important site of lymphatic drainage. And seen sonographically here, ascending from level 4 up through, centering the carotid sheath in the middle of the screen, through the region of the thyroid, and seeing lymph nodes that are surrounding the jugular vein. These are typical benign lymph nodes that have no pathology but vary in size throughout the different levels of the neck. But a similar view sweeping through the neck in a patient with metastatic papillary carcinoma, you will see metastatic lymph nodes of varying shapes and sizes, some with microcalcifications, most with loss of a visible hilum, many with increased vascularity if you were to apply Doppler. And these are not to be missed in the patient who might have a microcarcinoma or a subtle camouflaged nodule in the thyroid in a gland that might have a dominant nodule that you're considering for radiofrequency ablation, but you don't want to ignore the rest of the thyroid and the surrounding structures. Here's a couple of still pictures of metastatic lymph nodes. On your left, a view of a metastatic node invading the internal jugular vein, and on the right, the typical cystic change of metastatic papillary thyroid carcinoma. So the structures that we're not often focused on when we're looking at pathology include the structures in the immediate vicinity of the thyroid gland, including the trachea, seen here, the carotid arteries on either side, the vagus nerves within the carotid sheath, which in this example are fairly lateral in the carotid sheath and far away from the thyroid. But in some patients, these happen to be medial and very close to the edge of the thyroid gland, which can be important when considering RFA and the ability to administer heat to the region of the lateral extent of a nodule. We have the esophagus seen in blue and the tracheoesophageal groove in green, which is also in the region known as the danger triangle, or the region posterior to the thyroid, most likely to carry the recurrent laryngeal nerve and be vulnerable to injury. But then there's also the sympathetic trunk, which is usually not seen posterior to the carotid artery, and even the relationship to the skin up at the superficial aspect, which when nodules are expanded and tense, can be very close to the skin, and one needs to keep in mind the risk of skin burn with RFA. Something else that we're usually not accustomed to looking at are anterior jugular veins, just superficial to the strap muscles, but are usually compressed when examining the thyroid. And here you see them in Doppler. But I would just say it's never too early to start to learn ultrasonography and to gain proficiency in this. And this is, again, the sine qua non for which RFA is guided. So I'll turn it back over to Dr. Noel, who will talk about the consent process. And let me stop sharing. And Dr. Noel, if you can unmute. There you go.
Okay. So we'll move on to the consent process and what to share with patients in terms of what to anticipate during and after the procedure, as well as the expected outcomes months and even years down the road. And this is a nice checklist that appears in the 2017 Korean Society of Thyroid Radiology guidelines, and it's very helpful to reference to ensure you've covered the necessary information with your patient. We'll talk about these first 5 in a bit more detail since they sort of nicely frame the discussion of expectations and outcomes. Treatment response and success in radiofrequency ablation is really measured in % reduction in volume from baseline. And the most rapid reduction typically occurs in the first 1 to 3 months following the procedure, but does continue at a slower rate of decline until around 12 months. After the first month, the volume is generally reduced to by about 1/3 to 1/2, and at 6 months by about 1/2 to 3/4. And at 12 months, ablation volumes can exceed 80 or 90%. And there's generally a plateau in reduction from about 12 to 36 months, but we do have some data from patients that have been followed for upwards of 5 years, from other countries that also show that this is followed by even further reduction around the 3-year mark. In functional thyroid nodules, the data is a bit heterogeneous and so has been somewhat difficult to synthesize, but euthyroidism can be achieved in the majority of patients, with complete withdrawal from antithyroid medications possible in nearly half and dose reductions possible in about 3/4 of the remaining patients. There are some features that are more likely to predict success in treating functional nodules. For instance, those with smaller baseline volumes are more likely to have complete cessation of antithyroid medications. It is somewhat intuitive that greater ablation volumes and size reduction are also predictive of the ability to achieve euthyroidism, with most studies reporting an average volume reduction of around 80% in the patients that do have normal thyroid function at 12 months of follow-up. Because of the hyperfunctional nature of the nodules and often the vascular nature as well, regrowth can lead to recurrent hyperthyroidism. And so it's just important to disclose this to the patient ahead of time and mention to them that it could take more than one session to adequately and durably control their hormone levels. And finally, for the larger nodules or nodular conglomerates, a combined technique can be pursued wherein a single RFA session is combined with radioactive iodine, which does allow for a lower dose of radioactive iodine to be given and often results in faster resolution of the hyperthyroidism. Because of the exceptional volume reduction that we see after just one treatment, for the vast majority of patients, a single session with RFA will be sufficient. The biggest caveat to this that's been identified and is somewhat intuitive is that larger nodules tend to be more likely to require additional sessions. The larger the nodule, the more difficult it is to ablate everything in one go, and there's more potential for regrowth from untreated tumor and blood supply. So we do consider additional treatments when patients have persistent symptoms or aren't satisfied with the cosmetic outcome. Can also be considered if that sort of 50% reduction in size that constitutes a successful ablation hasn't been achieved, or for significant nodular regrowth. And for patients who undergo 2 RFA sessions for large nodules, there does seem to be a slightly greater and more durable reduction in volume from that second treatment. The optimal timing of this is still under debate, but has been suggested to be around 1 year, just to allow time for complete involution of the previously ablated tissue. One of the most common questions from patients and providers is, what are the chances that the nodule will grow back? And long-term studies suggest that depending on how it's defined, regrowth does happen in anywhere from 5 to 25% of nodules. If it is going to happen, it can become apparent as early as a year, but is more commonly seen around the 2 to 4 year mark. And it most often results from marginal regrowth, meaning that under or untreated areas at the periphery of the nodule can fill in over time. And this is in part why location plays such a significant factor, because the likelihood of regrowth is much higher when there are parts of the nodule that you're unable to treat. For example, in the nodule that is shown here, which occupies the right lobe of the thyroid gland, this red triangle represents that sort of danger triangle where we are not going to ablate because we don't want to cause damage to the recurrent laryngeal nerve. And this means that there will be some remnant nodular tissue that may regrow over time. The same is true for nodules that are close to other important structures, which is why we emphasize the importance of just paying close attention to the relevant anatomy on ultrasound when counseling patients on what to expect. Pain is the most common reported side effect during the procedure. It's generally not significant and is very temporary, but you shouldn't be surprised to hear patients reporting discomfort not only in the neck, but sometimes in the jaw or teeth, the ear, the shoulder, back or chest. And fortunately, this can be almost eliminated by the adequate application of topical anesthesia, after which patients tolerate the procedure quite well. The sensory nerves, for the most part, are on the capsule of the thyroid gland. So this is the area that you really want to target with local anesthetic. And you can see in the photos on the left here, there's a needle trajectory sort of along the anterior capsule of the thyroid gland here, and then the posterior capsule here, which serves the dual purpose not only of delivering anesthetic, but also of lifting that nodule off the thyroid cartilage, which was sort of positioned in the pyramidal lobe. And finally, I should mention you can choose to perform RFA in the OR as opposed to in the office, which allows you to use general anesthesia, but you should be aware that your ability to assess for and try to intervene on complications, particularly nerve damage, will be limited. Thankfully, this is a very safe procedure, and there are a number of studies that include large numbers of patients that have established an overall complication rate of around 2 to 3%. And this particular table is borrowed from a multi-center study of almost 1,500 patients with benign nodules. Because of the very targeted nature of the treatment, the incidence of a recurrent laryngeal nerve or a vagal nerve injury is quite low, around 1%. And as I mentioned on the previous slide, it's really one of the primary reasons to have patients awake during the procedure, so you can get that real-time feedback about voice changes. Nodule rupture is uncommon and thought to be the result of delayed bleeding and subsequent tearing through a weak point in the capsule of the nodule. But one of the real advantages of RFA is the ability to preserve normal thyroid parenchyma, which results in a drastically lower risk of hypothyroidism compared with surgery. And you can see here that out of these almost 1,500 patients, only one developed hypothyroidism in the follow-up period. Other types of nerve injury are rare but reported and can include injury to the brachial plexus or sympathetic chain. And the more minor complications and side effects are for the most part self-limiting and can be managed conservatively. Hematoma and skin burn can be mitigated by always paying attention to where the tip of the needle is, making sure to avoid large vessels or being too close to the skin. Coughing is another side effect over which we have some control, and often just means the trachea is getting a little bit too much heat, so the power can be reduced or you can just move to another location within the gland. And then briefly, some recommendations for postoperative care. If any pain medication is required, Tylenol is almost always sufficient, and many patients say they don't need anything after the ice pack on the ride home. We let them know to expect some swelling and increased firmness in the nodule for the first few days after the procedure, before the size starts to noticeably decrease. There are no restrictions on diet and very little downtime. Patients can work the next day, and in most cases resume full exercise after a couple days. Okay, I will conclude and stop sharing my screen.
Okay, thank you. And I would just reiterate the ability to preserve thyroid function is really, it can't be overstated how important that is. The fact that this is scarless, that there's no downtime, that it's relatively painless, and that it has relatively rapid results is, I think, superseded by the, or just expanded by the fact that the avoidance of thyroid hormone replacement and preservation of normal tissue is so important. So I'm going to talk about anesthetic and ablative techniques under ultrasound guidance. And I can't overstate also that preparation is paramount. Preparation in terms of ultrasonography proficiency and preparation in equipment setup, so that during the procedure things are seamless and comfortable to both the operator and the patient. And so we've decided that we have a classic benign thyroid nodule seen here in transverse and sagittal view that's an ideal candidate for RFA. It's had 2 benign biopsies, but it also has very innocent sonographic characteristics. We can examine, we see the larynx there, and we can examine the thyroid, both lobes, The right lobe has this nodule, but it doesn't extend beyond the view of the operator, so it should be accessible to RFA. And the left lobe is also important to examine. This patient in particular has a relatively normal appearing left lobe and a very homogeneous texture to the thyroid, but nothing is out of reach from the uh, operating perspective. And for those of you who have experience with ultrasound-guided fine needle aspiration biopsy, the technique is fairly similar. We first localize the target of interest and optimize the straight line access to the target. So on the right here, on the left, you see a nodule that's going to undergo fine needle aspiration biopsy. You try to localize the surrounding structures, the structures that might be vulnerable in the vicinity. And then on the right side, this is a transisthmic fine needle aspiration biopsy using the parallel technique for ultrasound guidance. And the parallel or long axis technique is one of two common techniques used for ultrasound guidance for procedures. Many individuals have learned the perpendicular technique and find that easier to master because it's more forgiving in terms of alignment of the needle with the ultrasound beam. However, you don't have continuous view of the needle, and the perpendicular technique does not lend itself to radiofrequency ablation. The parallel technique is a little bit more difficult to master because it requires aligning the beam of the ultrasound with the needle in a parallel and direct linear situation. But the RFA probe that's used is slightly larger than a fine needle used for FNA, so it is easier to see than an FNA needle. FNA needles are typically in the range of 25 gauge or 27 gauge, whereas the RFA probe is typically in the 19 gauge vicinity. So the equipment that's needed beyond the ultrasound system and proficiency with it is just an RFA generator, which contains a pump and coolant. The coolant is usually just ice water, and a radiofrequency probe, which is single use or disposable. Beyond that, the items are typically readily available: a sterile transducer cover, sterile gel, 1% lidocaine, as well as D5W, which can serve as a heat sink to hydrodissect, and it can also extend the lidocaine and reduce approaching toxic levels. Syringes and needles, in particular a spinal needle to administer the majority of the local anesthetic. Some of us prefer to use an 11 blade to make a very tiny nick in the skin through which we introduce the radiofrequency electrode, because there is some resistance to insertion through the skin without a nick, and the probe can get dull over time. But this is optional, and if used, it doesn't create any permanent scar. A sterile drape, a shoulder pillow, sterile gauze, skin prep, and then just a Band-Aid and an ice pack for the aftermath. So from an ergonomic standpoint, RFA is performed via a transisthmic approach, and this may be different from how fine needle aspiration biopsy is performed. But the safest route to access a thyroid nodule in either the right or the left thyroid lobes is to come from a medial to lateral approach through the isthmus and coursing toward the carotid sheath. This is safest for protection of the recurrent laryngeal nerves and the trachea. It's also most stable if the patient swallows during the procedure. And since this procedure typically requires anywhere from 15 to 30 or more minutes to perform, the patient will definitely be swallowing repeatedly as well as breathing and moving somewhat, but the probe can be stabilized by transmitting it through the isthmus of the thyroid. The isthmus also provides insulation and some vascular ablation in the course of radiofrequency ablation. The operator can choose to sit at the head of the bed and be ambidextrous, such that left thyroid nodules are ablated with the electrode in the right hand and right nodules are ablated with the left hand. Or if someone is particularly handed or dominant in one hand or the other, for example, right-handed, they may choose to sit or stand at the patient's right side facing toward the head for right-sided thyroid nodules, but come around to the head of the bed facing the feet to ablate left thyroid nodules via a transisthmic approach. Either way, both the patient and the operator must be comfortable to be able to complete this procedure effectively. Here is a typical male patient with a large right thyroid nodule that has a benign appearance on ultrasound and has had benign fine needle aspiration biopsies. When assessing this patient for candidacy, beyond knowing that it's a cytologically benign nodule, it needs to be accessible to a straight line route for the RFA probe. And so typically the site of entry will be at about the midpoint of the nodule, but the RFA probe will be fanned out through the superior, mid, and inferior aspects of the nodule. And it's important to recognize the relationships with the trachea and larynx, as well as with the mandible and clavicle, because sometimes these bony structures prohibit access to the full nodule. Local anesthetic is administered by hydrodissecting, and this just involves not only delivering the anesthetic, but because it's a dilute or low concentration lidocaine and can be extended with D5W, it provides infiltration of fluid that creates a barrier between the thyroid and adjacent structures. It can be very helpful to have an assistant push the plunger on the syringe that contains the anesthetic in order to keep track of the amount of anesthetic delivered while the operator's attention is focused on the patient and the ultrasound screen, but also because when the syringe is loaded up, it can be hard to reach the plunger with the thumb. But this is not mandatory, and when administering supplemental anesthetic, it can be in small aliquots that can be done by the operator. But on the right side of the screen, you see the superficial injection. Here's ultrasound guidance of the needle out to the lateral extent of the thyroid nodule toward the carotid sheath, but not into the carotid, and delivering anesthetic that is elevating the strap muscles and creating a fluid layer between the thyroid capsule and the strap muscles and providing anesthesia in the process. The other location, as Dr. Noel mentioned, that's important to anesthetize is the region adjacent to the trachea, both for protection of the trachea and for pain relief. And here you see that it's a somewhat more difficult trajectory to achieve in a straight line given the arc of the trachea. In this example, this is a transisthmic approach to the region between the trachea and the thyroid nodule, but this can be approached from a more lateral direction just to administer anesthetic right against the perichondrium and medial aspect of the thyroid. But you'll see here momentarily that infiltration of anesthetic in this region creates a little bit more space between the nodule and the trachea and provides pain relief and numbing in the process. So here you see the expansion of the tissue, and here just a little bit more expansion as the anesthetic infiltrates. But we don't go down all the way to the posterior border of the trachea for fear of administering anesthetic to the recurrent laryngeal nerve. Here's a patient with a left thyroid nodule seen in the typical diagnostic ultrasound view with the operator facing the head of the patient, transverse on your left, sagittal and Doppler on your right. And here is a sweep through the thyroid showing the extent of this thyroid nodule. It has a small cystic component, but it's mainly solid. And now when you come to performing radiofrequency ablation, you have to flip the image in your head. You now will see the operator positioned at the head of the bed facing towards the patient's feet. And so a left thyroid nodule will appear as inverted. And it's important, as shown on the right side of the screen and in this view here, to pay attention to things like the vagus nerve and the anterior jugular veins that are surrounding the thyroid, and the danger triangle trachea and carotid artery, which are to be avoided. So this is the typical position with, in this case, holding the transducer in the left hand and the electrode in the right hand for a left-sided thyroid nodule. The ablation takes place, as shown here on the right, by introducing the electrode and advancing it to the distal point of the targeted ablation and activating the foot pedal to ablate while withdrawing the electrode toward the isthmus of the thyroid. And here, this is done in layers, advancing to the far reach of the thyroid nodule and then ablating as the probe is withdrawn back towards the site of entry. So this is using the moving shot technique where the electrode is active as the electrode is being withdrawn, going from deep and medial to superficial and lateral, ablating at the lowest power setting possible, and visualizing the the active tip of the electrode at all times. This is done in repeated layers from inferior to superior or superior to inferior in the longitudinal plane. And again, here just showing repeated layers of ablation systematically, sequentially from deep to superficial. And I think you're going to see this a lot more thoroughly in the video that's up next. So I would like to turn the podium over to Dr. Rangel, who's going to narrate a video that he created of a patient on whom he performed radiofrequency ablation. So I'll stop sharing my screen here and you can take it away.
Okay. Thank you, Lisa. Amazing presentations. So, are you seeing my video perfectly?
Yes, we see the opening screen.
Okay. So, my name is Leonardo. I'm from State University of Rio de Janeiro. It is a pleasure to be here. Thank you, Lisa. Thank you, Julia, for the invitation. So today I'm going to present a left lobe solid autonomous nodule with initial 13 cc of volume. Here. This is a completely solid nodule. So we can see it's occupies almost all the left lobe of the patient. It is fairly vascularized, as we see here in the Doppler. The vascularization is not the highest, but we definitely see some vascularization inside the nodule. In the scan, we can see a hot nodule on the left side with almost subclinical hyperthyroidism. So as Dr. Lisa showed, the nodule evaluation and setting the boundaries of the nodule and make sure that you can reach all sites of the nodule is paramount to the procedure. So we set the here with the purple lines, horizontal lines, the superior and inferior side of the edges of the nodule, and we make those fans with those blue lines so we can see the trajectory of the needle. As Dr. Lisa beautifully demonstrated, first we use the lidocaine to set the hydrodissection and numb the initial subcutaneous skin trajectory, and then also make some hydrodissection in order to protect the skin and really numb the thyroid capsule so the patient can really perform a painless or pain-free procedure at all. So first we do just with the lidocaine here. After we finish with the area over the thyroid, just with the lidocaine, we will move for with the D5W when we go over the carotid. So here we are finalizing just the area over the thyroid nodule. When we need to go with the 5DW, generally with larger nodules that are in contact with the carotid, those large nodules, we definitely would need to go over there. And sometimes, and that's when we use the spine needle that are larger. Sorry, they are longer. We can for the hydrodissection, sometimes we can go from lateral if needed. If the nodule is too bulky and we cannot go over the nodule, there is not a problem to go lateral with the spine needle and try to get the carotid space away from the nodule. But generally we go from the same site and use the same skin puncture so the patient do not feel several skin punctures. And stings. Okay, so we use the spine needle to go through the nodule, over the nodule, and try to reach the area over the nodule, over there with the. So it is important. So observe how we can bend the spine needle here in order to make a curve over the nodule, and really try to get that capsule between the strap muscles and the thyroid, so we can find that space and really open an area that we can put some liquid there and make that heat sink effect and protect the carotid, protect the vagus nerve, and especially refrain the patient from having some referred pain they may have in the jaw or the teeth when we have when we apply heat very close to the carotid. So it is important to be really aware of this, so we make the procedure very comfortable for the patient, and we do not need to interrupt the procedure during the ablation. Okay. And now starting the radio frequency per se. Here we really need to position the electrode, as Julia demonstrated, as deep and as medial to the trachea, close to the trachea as possible. So we actually start the procedure at the most dangerous place. We start as close to the dangerous triangle. So that's why we really start with lower power. And if the energy needs to be increased, we increase it stepwise approach with some 5-watt increase each time. So when we start the ablation, yes.
It's very interesting to note how comfortable the patient are.
Yes, when we start, and it's important that we speak with the patient at all times. So yes. We check the voice and how the patient is comfortable. So here we see the changes that the ablation creates at the thyroid nodule. When we start the ablation and the temperature increases to almost 100 degrees Celsius, the tissue becomes instantly hyperechoic, and we have a shadow below that area. So if we, that's why we start with the deepest part of the nodule. So that tract that we created is destroyed. After we finish that tract, we reposition the electrode in the same section, and we reposition it a little bit superior and lateral. So we create another tract at the same section of the nodule. We are treating here the mid portion of that nodule, okay? And this is important for a stepwise approach. That's what the kind of systematization that Dr. Lisa was speaking about. If you do ablations randomly, you will lose how the areas that you did ablation and the areas you did not ablate.
Angel, may I make a comment? Yes, you said about the aspect of the ultrasound to see that the tissue was ablated, but I think it's important to notice this area of the impedance, the machine. You can see the impedance, and here you can see the power. So when the impedance goes up and the power goes down, at the same time, you have the ablation of the tissue, right?
Yeah, it is important. Yes, we'll talk a little bit about this. So, and here we are finishing the most superficial part of this section. After we finish this section, we can check a longitudinal section. We make a longitudinal section of the nodule, and we can clearly see that area that we treated one section, one small section of the thyroid, the nodule that was ablated. So then after doing this section, we have to repeat the procedure in all other sections of the procedure, of the nodule, remembering that the area that we actually ablate is between 5 millimeters. So as the larger the nodule, larger this, the highest are going to be the sections that we will need to treat. So we need to repeat it several times in larger nodules compared to smaller nodules. So as Gino was commenting, here on the generator screen, we can see that 5 watts is the power set, the superior limit that will not deliver more than 50 watts in this nodule, for example. And on the red numbers are the watts being delivered, and the yellow number is the impedance. So as the impedance increases, the delivery of the energy will decrease. So that's why we generally, if you observe when I'm doing the procedure, sometimes I tilt and I twist a little bit the electrodes. So if we get a little bit of char into the active tip, we can get a little bit rid of the char, and the energy increases again. So this is it's very important. We don't have a magic number with which the impedance will actually affect the ablation, but we really keep track of the amount of energy being delivered and the characteristics of the ultrasound, so we can check if the nodule is being treated or not. Here we can see that the fan movement that we do, so we check, we can reach the inferior part of that nodule. See, we are using the same entry point, and we make a fan movement. So that's why it's so important to master the fine needle aspiration procedure and technique in order to do this kind of procedure. So once you can really do this, the fine needle aspiration, you are ready to move to radio frequency, okay? Because it's a little bit harder to do this than it is to do the fine needle aspiration. So here we can see how we are doing the procedure in a very systematized approach in order to get all the nodule covered. It is very important.
It looks like you were just having the patient talk to you, or she was telling you something, but you're testing her voice. Is that right?
Yeah, she actually wanted to ask about the procedure, how it was going and stuff. You know, Lisa, Brazilians really like to talk. So she was trying to make small talk during the procedure.
Yes.
I think that is important to talk to the patient, to monitorize the nerve function too. So
yeah, definitely.
You don't have monitor the nerve, so you can talk and see if the voice is okay, or so it's a good way to monitor the voice of the patient.
Leonardo, when do you use in some situations a small cushion under the shoulders of the patient?
Yeah, the position is almost the same position that we use for thyroid surgery, but I would say that we use a slight smaller cushion because as it's a awake procedure, sometimes the position may be a little bit tiring for the patient and may a bit discomfort. So maybe if you can see the whole nodule with the patient extending the neck, I think that we should find the most comfortable position for the patient, as long as you can see the whole nodule in the neck. So this patient has a long neck. It's way easier than the patient that Lisa showed, that big guy. Definitely that guy would be more challenging to do. And another thing, this nodule as autonomous nodule, we have two main goals while treating this nodule. We definitely need a reduction of the volume, but we also seek the treatment of the function of the thyroid. So we see here, as we are treating, we are trying to leave as little as possible for margin as possible to of being unablated. And when we finish here, we will use another technique that we cover the move and shot technique that of the radiofrequency ablation per se, but we also use some other techniques like hydrodissection and also vascular ablation. So it is important to have, after we do all the procedure, all the ablation, we see the area of the nodule ablation, we check the remaining vascularization. So we identify, after the ablation, we have some artifacts because of the ablation, but we definitely can observe here a residual subcapsular vascularization vessel. So we should take care of that vessel. I'm using the Doppler mode on, but we do not, if you identify the vessel, you can change for the B mode, but just for the sake of showing, we use the ablation, we insert the electrode inside the vessel and we deliver the energy. So you can observe that we can treat a little bit longer because of the heat sink effect by treating the vessel. But after we perform this ablation, we remove the electrode to reduce the artifacts of movements, and we see that the vessel is treated. Hope to see you in Rio. We really miss you all, guys, about the COVID. This is Lisa with our residents and Noel. Thank you so much, and hope you guys are all well.
Well, thank you so much, Leonardo. We, Dr. Noel and I are really standing on the shoulder of you giants in Brazil who have a longer and more extensive experience with this, and we're our mentors. And it was a privilege to be able to learn in a hands-on way from your course. Now I would like to introduce our colleague, Dr. Erivelto Volpi, who will be speaking on long-term outcomes and follow-up after radiofrequency ablation. Actually, do we have Dr. Volpi or do we have Dr. Steck?
Whatever.
Are you ready, Erivelto?
Yes.
Great.
Okay. Can you see?
Yes, perfect.
My screen?
Yes.
Okay, great. First of all, thank you, Lisa. Thank you, Julia. It's a great pleasure to be here with friends, with colleagues. It's an honor to share our experience in this meeting. Thank you very much for your kind invitation. As you said, my name is Erivelto Volpi, and we will talk briefly about the outcomes and the follow-up of our patients treated with RFA. Well, this is our minimally invasive thyroid group of thyroid therapies. In addition, we started this group 2 years ago, something like this. In addition to me, Leonardo and Gino, we have another colleagues had joined to our group, such Dr. Evandro Vasconcelos, Dr. Elaine Stabenov, and Dr. Antonio Raal, among others in our group. We are very happy this group is increasing, growing very fast. Well, Today, we live in a time of significant changes in treatment of thyroid nodules. New forms of therapy available, and the way we understand the behavior of this kind of disease had led us to develop new minimally invasive treatments, which results very similar, at least, to conventional treatments when correctly indicated. The main goal, the main point is to correctly indicate this kind of procedure. Well, we are going to show this year at a Congress our experience with RFA. This study had been accepted for oral presentation. Unfortunately, due to the COVID pandemic, the Congress, as you know, was canceled. But it's important to note nowadays that our group has more than 200 cases and with really encouraging results. This series is from 84 thyroid nodules in 70 patients, with the mean age of the patients with 46 years old. The mean nodule volume was 14.5 cubic centimeters, with the mean follow-up was for 4 months. Well, this graphic shows the volume reduction curve of our patients with thyroid nodules treated by RFA. It's important to note how in the first 3 months, there is a rapid decrease in the volume of the nodules, with a very significant decline in the subsequent months, albeit in a lower rate. It's interesting to see in 6 months, the volume rate of the nodules was less than 50% at the beginning, which is very good results. Well, here we see how the reduction volume of the nodules progresses. In the first month, the median rate was 35% of the initial volume of the nodule. After 3 months, 57% of the initial volume, and 57% the rate of reduction. And after 6 months, 70% was the mean reduction rate of the volume nodules. It's very interesting. It's very good results in our series. This spaghetti graphic show the evolution of each nodule of each patient, and as you can see in this picture, the vast majority of the nodules, even huge nodules, decrease. But I want to call the attention for this nodule that at the first month it grows a little, and that could happen in some situations due to the inflammatory process of the ablation. But then, after 1 month, the nodule starts to shrink, and then goes very well after them. And some nodules could grow a little, but then they could shrink after the time, as time goes by. Our complication rate was, we don't have very major complications so far. We have 80 patients with minor complications. Ecchymosis in 3 patients, it's a very common complication for us. Skin allergy also in 3 patients. Temporary hoarseness in 2 patients, cough for 15 days in 1 patient, and dysphagia in for 2 days in 1 patient. Most of those complications are very well tolerated by the patients, not requires a special treatment. One good tip when you do the RFA, is to put ice cushion in the neck of the patient. Sometimes when they have immediately after the surgery, after the RFA. Well, after this very fast explosion, I want to show that radiofrequency ablation, it's a very good treatment option when well indicated, with very good results in our series. And we truly believe that in the near future, when the colleagues got more experience with this kind of treatment, RFA could be the first line option for the treatment of benign nodules. Once again, thank you very much.
Thank you so much, Dr. Volpe. And now I'd like to introduce Dr. Jose Higino Steck, who's going to address the mixed solid and cystic nodule. So we'll switch the screen share and
okay. Thank you, Lisa. Thank you, Julia, for the invitation. Can you see my screen?
yes, we can. That's great.
Okay. So thank you for the invitation. It's an honor to be here and to talk about my talks about the management of mixed thyroid nodules. I am Higino Steck from Campinas, Brazil. And the objectives of this presentation is to present the management of mixed cystic and solid thyroid nodules with ultrasound-guided RFA, and present the ultrasound features that most respond to radiofrequency ablation. Let's begin introduction the subject. We know that most of mixed thyroid nodules are benign, but we need FNA from the solid part of the nodule to confirm it's benign to perform the radiofrequency ablation. And the main indications for RFA in benign nodules are the symptomatic and cosmetic problems and hyperfunction nodules that can be encountered in these mixed nodules.
Excuse me, Dr.
One of the first...
Dr. Steck, do you have slides? Are you showing slides right now? Because we're not seeing your slides.
No? And now?
No. No, are we, we'll have to, if you share your screen. We're seeing you, which is wonderful. We like to see you, but if you've prepared slides, here we go. There they go. Thank you.
Okay. Sorry, I don't know what happened, but
no problem.
Let me see if okay.
No problem at all.
Okay. So, it's okay?
Yes, that's perfect.
So I'm going to talk about the mixed nodules. And one of the first papers about the subject of RFA is from Korea. And they showed that the volume reduction was about 85% in 6 months. This paper showed that in 1 and 3 months, the mainly cystic nodules decreased more in size than the mixed and the solid nodules. And the mixed nodules decreased more than the solid nodules. But after 6 months, the amount of decreasing, the volume decreasing was the same. And what are the essential skills to be able to indicate and perform RFA? Lisa said the most important is the ultrasound and perform your own ultrasound. This is very important to do the RFA. And in the ultrasound, you can see some structures of the nodule that are better for the effect of the radiofrequency ablation. For example, the sponge-form pattern can arrange a reduction rate of 76%, is a little bit more than the mixed nodules and the solid nodules too. Vascularization is important too. If you have intense peripheral and intranodal patterns of vascularization like this one, you can achieve more reduction volume than less patterns of vascularization. Calcification like this did not correlate with the volume reduction, but the volume of the nodule itself is has a slight inverse correlation with the shrinkage of the nodule. So greater nodules has less reduction rate, the reduction of the volume ratio than the smaller nodules. And some effects you can see in the ultrasound to see that the ablation was good. One of the first is the hypoechogenicity that you can see here. The nodule after the ablation is more hypoechoic. And you can see a decrease of the vascularity of the nodule too. You can see here, here is before and here is after. This picture shows it better after the ablation, almost no vascularization at all. And you can see also a reduction of the elasticity. The nodule became more hard and you can palpate it, or you can see in the elastography if you perform it. Calcification can be apparent after ablation too. And here is a core biopsy that we did just after the ablation, and you can see tissue necrosis inside the nodule caused by the radiofrequency ablation. And what is the approach of the mixed nodules? We can say about the simple approach. You can divide the mixed nodules in pure cystic or 90% cystic, more than 50% cystic, and less than 50% cystic that includes almost all solid nodules. You can do ethanol ablation or radiofrequency ablation for pure cystic nodules like this one. But this randomized trial from Korean group showed that the success of the therapeutic with ethanol ablation and with radiofrequency ablation are the same. So you can do ethanol ablation for cystic pure. But for the mixed nodules, you can have the predominantly cystic nodules, more than 50% cystic, like this one. And this randomized trial, also from the Korean group, said that there is a slight better result for the radiofrequency ablation compared with ethanol ablation, but it was not significantly statistically significant. And this other paper showed that predominantly cystic nodules with 50 to 90% cystic components had a percentage of patients with unsatisfactory results of the treatment of ethanol ablation. That was 26 to 33% of the patients. And the patient that has that the ethanol ablation was less effective was the patient with a solid component, more than 20%, how you can see in this graphic. More than 20% the unsatisfactory results are greater with the ethanol ablation. So it was proposed the ethanol and radiofrequency combined therapy. So you need to consider this with a solid component more than 20%. This paper showed that you can combine ethanol and radiofrequency to treat these mixed nodules in three ways. The first, you can perform a radiofrequency ablation after ethanol ablation if you had unsatisfactory results. The second way, you can perform an ethanol ablation after radiofrequency ablation if you have some residual unablated solid portion. And third, you can do the concomitant procedure with ethanol injected at the same time of radiofrequency ablation. For example, in a case where you aspirate blood and you see a venous oozing after aspiration, like in this case. Here on the left-hand side, a small video showing the aspiration of the liquid part of the cystic nodule. And the right-hand side, you can see a small video showing the injection of the ethanol in the cystic part of the nodule. This another video is the radio frequency of the same nodule. You have to notice that the image is inverted because it was a left side nodule, and in this case I am in the head of the patient to perform with my right hand the transisthmus approach. Here we are doing the moving shot technique, how it was demonstrated already. And this figure, this picture, Erivelto showed already, is this patient with a huge mixed nodule, and before the ablation, and you can see a good effect after the ablation after 6 months. The nodule is there already, but the cosmetic effect is very good. And finally, the simple approach to less than 50% cystic nodules like this one. For this kind of patient, you don't need to use the ethanol at all. You can aspiration first, if necessary, the liquid, then you perform the radiofrequency ablation, because the RFA does not work with the liquid part of the nodule. This is a case of a female, 24 years old. It's a benign nodule with progressive growth, and 2 FNAs showing it's benign. And the nodule is visible in the neck, how we can see here. Here is the aspect, predominantly solid, the nodule, so, but we don't need to use ethanol in this case. Here, before the ablation, we can see the volume is it's not a very big nodule, but it was apparent in the neck. And this was the complaint of the patient, showing the vascularity of the solid part. And after 6 months, you can see a very good result with 96% reduction. The volume of the nodule was 0.1 cubic centimeters. It almost disappeared, except for this calcification that we know that the radiofrequency don't act in calcified tissue, and no more vascularization too. So it was a very good result. This is the cosmetic result before the ablation and after the aesthetic was better. So, in summary, the simple approach to mixed nodules. For pure cystic nodules or 90%, ethanol ablation is okay to perform. For more than 50% cystic and less than 9%, you can consider ethanol radiofrequency combination therapy. And less than 50% cystic, you can just aspirate the liquid and perform the radiofrequency ablation without ethanol. And the message that I want to take to home is the RFA requires ultrasound skills. It's the most important, it's the sine qua non, like Lisa said. And good results you can achieve from mixed nodules with radiofrequency alone or combined with ethanol ablation when it is indicated. Thank you.
That's wonderful.
Stop sharing your picture, Lisa.
I like that. Thank you.
So I think we have a couple of questions that we deferred from the Q&A while everyone was speaking. And perhaps we can go to those first. So everyone feel free to chime in as needed. But so the first question was, can you comment on larger nodules that are greater than 4 centimeters, even though there's a higher risk of follicular neoplasm on FNA? And if these nodules continue to enlarge after RFA, are there any false positive findings if you repeat the FNA?
Yeah, there is a good question. Many people ask that question. Even the last ATA guidelines, they address that issue on the Bethesda tube on large nodules, and albeit some papers would consider the higher incidence of malignancy on those larger nodules. Many papers disagree with that. So I think if we have a very homogeneous nodule that is a Bethesda 2, if ultrasound characteristics are very benign, it shouldn't be a problem to treat that nodule. But if the nodule is intermediate or high risk in the ultrasound, and you're not so sure on the fine needle, maybe association of molecular testing or in Korea or in Brazil, that molecular testings are still very expensive. Core needle biopsies would be at some advantage, and maybe an option to even determine with more accuracy the benign characteristics of the nodule. But it wouldn't be a problem per se. And we are radiofrequency. It is a method to treat larger nodules. It's not to treat those smaller. If the nodule is 2 centimeters or less, if it's benign, you don't need to do anything, nor surgery or radiofrequency.
I interpreted that question slightly differently. I thought it was referring to a so-called higher false negative rate of FNA above 4 centimeters, which is also debatable. And you kind of mentioned that, Leonardo. I think the false negative rate of FNA shouldn't be more than 5%. But if, there's always the option of repeating a biopsy beyond a second biopsy. You can biopsy definitely with ultrasound guidance to target the more solid or most suspicious area of a nodule. But as you mentioned, I think that consideration of molecular testing can also help with stratifying those nodules further.
Okay, and then the second question that we deferred was, how did you navigate the financial aspects of starting an RFA program at your institution? And this was sort of a question that was a little bit specific to academic institutions in the US. But I think would welcome commentary from anyone who has had the challenge of starting this program in their own institution.
So that must be someone who has familiarity dealing with bureaucracies. So this is an issue that is as yet somewhat unresolved in the United States as far as what insurance companies will pay for this procedure. The fact that there isn't a specific CPT code for ultrasound-guided radiofrequency ablation of thyroid nodules makes it somewhat difficult to predict ahead of time what will be reimbursed. And we have been using the unlisted endocrine procedure code, which is sometimes a red flag to the insurance company to reject payment. So at least in our experience, we had to have a long drawn out discussion with our institution about overhead and what other radiofrequency ablation procedures were being performed at our academic medical center in order to gather sort of the spectrum of costs in terms of insurance coverage, cash price, and RVUs. And we practice in a very high cost of living area. So a factor of local overhead was it considered imperative by our administration. So I think that it is a dance that's done between those of us who want to bring this to our patients and make it affordable to everyone, and the administration that wants to be sure that all of the sort of indirect costs as well as direct costs are covered. But we are encouraged to say that we're seeing that Medicare is reimbursing for this. And it sometimes requires a letter of appeal. Depending on how savvy a patient is up front to work with a Medicare claims advisor, there can be approval obtained for complete coverage of the procedure through Medicare. And as goes with a lot of procedures, Medicare is often seen as sort of the standard by which other commercial insurers will determine whether something is reimbursable or not. So it's a drawn out process. I think Dr. Noel and I, it took us nearly 8 months of negotiating with our institution before we could actually start offering the procedure. But for those of you out there who are in solo or group practices, I think that the barriers will be less, and we have ample documentation thanks to, especially as the other speakers mentioned, a decade of evidence from Korea and from Italy and from Austria and from the UK. We don't have a lot of evidence from the United States. We're in the process of trying to create that evidence to have more ammunition, but there is ample decades-long evidence about the outcomes and the cost effectiveness of RFA in saving operative costs and thyroid hormone replacement costs. So, you know. We seem to have lost Dr. Noel. I don't know.
Yeah, we lost her.
Yeah.
But she'll be back, I'm sure. So I think somebody asked about RFA, Dr. George, hi there, about RFA for parathyroid adenomas. And there's very limited, Dr. Rangel answered this in the chat, but I just wanted to add to that, there's been very little published data on this. The number of cases is very small. As Dr. Rangel mentioned, this is a very low morbidity, low risk surgical procedure for the specifically well-localized, accessible parathyroid adenomas. So the very same nodule or a parathyroid that's going to be easy to do an RFA on is going to be very easy to remove surgically. The superior parathyroids and the deep parathyroids aren't going to be RFA candidates anyway, but the technique involves a lot of hydrodissection around the parathyroid to try to minimize collateral damage. And yet I think there's still a very real risk of parathyromatosis or seeding of neoplastic parathyroid tissue into the neck, which would make this, I think, a procedure that should be approached with great caution.
Yeah, I totally agree with that. It is the area that I think is the grayest area of all is the parathyroid. I think it is easier to foresee the use of radiofrequency in papillary microcarcinomas than it is in parathyroid.
Yeah. Yeah, there's Dr. Noel is back.
I'm back. I'm sorry. I had some internet connection interruptions. We also had, yes. Just because this was asked a couple different times, maybe one of you could comment briefly on the application of RFA in multinodular goiters.
I'll let you all.
Here in Brazil, I suppose Higino and Rangel have the same opinion. We treat a little bit different from other places because due to the cost of the procedure in Brazil, we try to use as much as we can. So we treat all that we can in a single section. So we usually treat 2 or even 3 nodules at the same time if possible. And we try to use as much as we could the same needle for the patient for the best results. perhaps even for a huge nodules, when sometimes the patient will need 2 or 3 sections for very huge nodules, we try to optimize and use the needle as much as we can. So it's the same. We try to use to treat 2 or 3 nodules at the same time if possible.
Yeah, this is a question of the, we're really at the verge of the philosophy of actually of the radio frequency. When we talk about radio frequency and try to preserve thyroid function with minimum thyroid and risks, we are actually trying to treat the nodule instead of treating the thyroid. But if we actually do not have a functioning thyroid or a very multinodular goiter with several almost to the decimal level of the nodules, we are really not treating the thyroid. So we actually are trying to reduce some nodule, but we are not going to avoid eventual surgery in the long run. So some cases I would discuss with the patient if the radio frequency is actually the best choice of treatment for her in the long run. For example, if the patient just wants to solve one huge nodule that she has at that point, and well, I will deal with my thyroid problem later on in my life, I think it's okay. But I would ask the patient, do you really want to do this and then have to do surgery at some point in life? And these are some questions that we have to ask the patients and discuss the pros and cons of each treatment. For example, treating a patient with hypothyroidism and one huge nodule. We are not treating the thyroid, we're not preserving the function, we're just treating the volume and solving that nodule. That patient would not benefit the most about this procedure. So this kind of discussion is a little bit patient by patient. But at this point in time, one benign nodule, huge, apparent, symptomatic, of normal thyroid function, I would challenge to discuss that this patient is not surgical anymore. This patient should be treated by radiofrequency and not treated by surgery anymore. That patient is patient for radiofrequency. All the other patients may be debatable, but this one nodule, benign nodule, apparent, symptomatic, with a normal thyroid function, that patient is for radiofrequency, definitely.
I think that is a place for even huge goiters, depending on the patient, what the patient wants. If he wants to avoid surgery, I think you can sometimes more than one session. It's preferable to do only one, but if it's very huge, you can do more than one. For example, for some substernal goiters, you can do first the part of the nodule that is not substernal, and then sometimes the substernal goiter goes up, and you can do it in the second time. So I think you can debate this kind of indication, but is a place for them too.
Any comments from the panelists on RFA versus other thermal ablation techniques?
Wow. Yeah, we don't have many head-to-head trials comparing more than one energy source. When we talk about thermal ablation in general, and the philosophy and the results are pretty much the same. what the microwave source is the least studied one. The laser was the first energy used by the Italians, and they have a slightest poor results with larger nodules. With smaller nodules, they work about the same as the radio frequency, but on larger nodules, radio frequency is a little bit better. And HIFU is also an option. As we have so far, we don't have also many reports. It is a very expensive piece of equipment, and is almost dedicated to thyroid. So you should have a very large clinic to be worthwhile. And the equipment that I saw, the margin that they leave is a little bit larger than the margin that we can leave with radio frequency. So we'll probably need more than one session to address this. And the patient cannot move because you program the area you're going to ablate, then you start the procedure. If the patient moves a little bit, the machine stops. So it's a little bit, it's not that easy. So, and radio frequency actually is the most available source of energy. So as Julia told, it's used on liver, kidney, bone. So it's the same equipment. You just change the electrode. So you should have one for your clinic, for your hospital. So it's just a matter of using the right electrode for the thyroid.
Okay. So I think we have hopefully addressed everyone's questions. And we're a little bit over time, so should we conclude, perhaps?
I think the hour is late, especially for our Brazilian colleagues who have stayed up late to be with us. And as much as we would like to continue talking about a subject that we're all passionate about, we will draw the webinar to a close. And thank you all for attending. As I mentioned, we're happy to answer questions after the fact, and we hope you've enjoyed this session. And we certainly have enjoyed hearing each other and discussing these issues together. And we're sorry we can't see you out there, but we hope you're all well and safe, and that you remain healthy, and you think about just increasing awareness of RFA for benign thyroid nodules. So thank you very much, everyone.
Thank you. Thank you all. Have a good night.
Thanks, everyone.
Thanks.
Bye-bye.
Thank you for the privilege. It was a great pleasure.
Thank you.
Thank you.
Thanks. Bye-bye.
Bye-bye, guys.